This next session, as I said, it's about communications in primary care, a topic which is one that I've worked on a lot over the last couple of years in my previous roles and now at National Voices. And you know, we hear a lot from patients and service users that how much of a difference communication can make to the access when they're trying to access care and the quality of care that they receive. And when I'm talking about communication, we're talking about deaf people, we're talking about people with learning disabilities, we're talking about people who don't speak English fluently or have low or no literacy, and many other different community groups who may struggle with communication with the NHS. And by communications, what we mean is the full range of interactions that someone might have with primary care. So be that letters or emails or text messages that you might receive from your practice. It might be phone calls about booking appointments, might be accessing the website to understand information about services available. It might be the signs and information provided actually in the surgery itself. Is that clear? Is that people understand that? It could be interactions with staff and the need for sort of translation support and interpreter support. It could be about communication about the primary care sector as a whole and how things are changing, or awareness posters. So we're talking about the whole range of communication that is available and the impact it has on people's experiences and quality of care. The aim of this session is to spread some of the learning that National Voices has developed in recent years through our engagement with particular communities and with through our members and our lived experience partners, and through our work with primary care partners, and to look at some of the actions that primary care can take to improve inclusive communication. We're going to start with a presentation of all of the work that National Voices has done from Dr. Rebecca Steinfeld, who is the Head of Policy and External Affairs, or one of our Head of Policy and External Affairs, part of the job share at National Voices. And Rebecca will be summarising some of the findings and recommendations from a series of research and focus groups and work that we've been doing. And after Rebecca, we'll have a panel join us, and I'll just introduce the panel briefly. Just for the benefit of panelists, the order I read your name out now is the order that we'll go in when we get to the panel section, but I'll introduce each of you in turn at that point as well, so don't worry, there's plenty of warning to bring you in. So joining us on the panel, we have Abigail Gorman, who's the Policy and Public Affairs Manager at Sign Health. We have Licia Fear, who's Head of Communications and Engagement for Healthcare Inequalities Improvement at NHS England. We have Gary Borley, who's the Membership and Engagement Lead at Learning Disability England. And we have Mihai Bika, who's the Campaign and Policy Coordinator for Roma Support Group. Each of the panelists will have about 5 or so minutes to give their reflections and thoughts on the topic and on Rebecca's presentation, and then we'll move into the panel questions. So without any more further ado from me, I'll hand over to Rebecca to present the work of National Voices on communications.
Thank you, Jacob, and hello and welcome to all of you today. As Jacob says, I'm Rebecca Steinfeld. I'm Joint Head of Policy and External Affairs at National Voices, and I'm in a job share. It's brand new, so I just wanted to give a plug to my job share partner, Sharon Brennan, who you can hear speaking later at 2:30, sharing our work about multidisciplinary teams in primary care. So what I want to talk to you about now is something we hear time and again at National Voices, that people with diverse communication needs are not having those needs met within primary care. And as Jacob says, that includes lots of different people, people with sensory impairments, learning disabilities, autistic people, people living with dementia, people who don't speak English fluently, and many others. And this matters because, as we've been talking about today, primary care services are the front door to the NHS. They're the first port of call when we feel unwell, and the main coordinator of care when we are living with health conditions. When communication is poor and people are not well served by primary care services, what they've told us is that this can lead to a breakdown in trust, and that in turn can lead people to avoid accessing services, either leaving their health needs unchecked and unmet, or accessing inappropriate services such as A&E. So the stakes here are high. In this presentation, what I want to share with you are the findings of a project we conducted to explore and unpack these issues in more detail with people with lived experience of diverse communication needs. I'm going to focus on 5 key areas. First, challenges that primary care teams experience in meeting diverse communication needs. 2, why communication matters. 3, key themes and proposed actions. 4, good examples of inclusive communication. And 5, policy improvements needed to support further positive changes. Can we have the next slide, please? So turning first to common challenges. Across our conversations with people who use health and care services and our review of the literature, a number of communication challenges were identified across all groups. These include inadequate record keeping around communication needs, leading to people repeatedly receiving information in inaccessible formats and having to advocate for the support they need at every contact. Failure to make adjustments that could benefit everyone who uses primary care. For example, avoiding the use of jargon and medical terms without explanation, offering large print and easy read formats, using pictures and icons as well as words on signs and instructions, offering to write down instructions for people to refer to later. Lack of continuity of care, leaving people unable to build relationships and having to repeatedly explain their needs, or leaving gaps in care, which results in unmet and escalating needs. Failure to treat people with communication needs with dignity and respect, and poor attitudes towards and assumptions about people with specific communications needs. Inadequate appointment times, leading to insufficient time to ask questions and clarify information provided. Poorly designed websites and applications which make access more difficult for people with specific needs. Lack of familiarity with how primary care is structured, including which services are provided in which settings and where to go for different kinds of support. And finally, lack of support for self-care and self-management among people with specific communication needs. Next slide, please. So why does this all matter? Well, I've explained the sort of breakdown in trust that can follow from people not having their communication needs met. But I think to really bring it home, we wanted to share some quotes with you, shared with us during this project, which shows the impact of this failure to support communication. So the first quote here is from Mihai from the Roma support group, who said, because she did not want to talk about personal issues in front of her son, who had been asked to step in to interpret, she did not explain where she was feeling pain. By the time her cancer was diagnosed, it was too late for treatment. Rachel from Groundswell told us, what good is telling someone they have an appointment in 2 weeks' time if they don't have a phone or calendar to note the appointment down? Abigail from Sign Health, who we'll hear from in a moment, said, NHS 111 allows me to call using a live sign language interpreter service, but then they want to call me back and the link is lost. And learning disability member told us regarding her son that because he doesn't use words to communicate, the move to the phone means he is cut out of conversations about his own health. So I hope that shows you the negative impact when people with diverse communication needs do not have those needs met. Can we have the next slide, please? Okay, so before I talk you through this somewhat wordy table, I just wanted to share with you what people told us were some of the key ways we can ensure good communication. They told us to avoid assumptions, use trauma-informed approaches, offer culturally appropriate support, offer consistency and continuity, be proactive in offering support, and avoid infantilizing adults with specific communication needs. So what needs to happen to enable this? Well, primary care teams need to ensure that communication needs are consistently recorded and flagged, improve all communications, optimizing them for accessibility, meet legal requirements around inclusive communication under the Accessible Information Standard and the Equality Act, for example, train the primary care workforce, and ensure more consistent access to sources of support in the community with a focus on what matters most to the person accessing care. This includes investing in and developing strong partnerships between voluntary and community organisations and the NHS. Now, that might all sound great in theory, but applying it in practice can be challenging. So that's where this table comes in. We've developed some practical tips here to respond to key issues that might come up in response to these suggestions. So on the left-hand side of this table, you've got the key issues, and on the right side are the proposed actions. So under key issues, one of the things that was raised is that many primary care staff don't feel confident in meeting diverse communication needs. So the actions that we've proposed are strengthening training on inclusive communications for primary care staff, creating new tools and guidance to support communication with people with diverse needs, sharing lessons and next steps from the recent review of the Accessible Information Standard with primary care teams across England, and creating standard procedures across health and care for common communication support requests. Another key issue is that people with specific communication needs don't always know what their rights are or feel confident exercising them. And one proposed action in this area is to develop simple tools to support people in communicating their rights to communication support. Digital has come up a lot today, and another key issue is digital systems, which could be used to record communication needs, are often underutilised or incompatible with systems used in other parts of health and care. Our proposed action in response to that is to strengthen the use of digital tools to flag communication needs and to include a focus on better meeting diverse communication needs within activities on improving the primary-secondary care interface. Accountability and leadership on the need to meet diverse communication needs within primary care are often weak. That's another key issue that's come up. And we propose appointing inclusive communications champions in every ICS and reviewing and strengthening regulation of primary care services, giving greater prominence to services meeting diverse communication needs. Finally, commissioning of primary care services often doesn't take into account the resource needed to support diverse communication needs, the importance of this, or how to do it well. In response, we propose creating guidance for commissioners on supporting inclusive communication in primary care and strengthening links between primary care providers and community-based organisations to improve access to support around communication. Can we have the next slide, please? So I wanted to share with you some examples of positive practice in this space which could be built upon. We've identified examples of positive practice that could provide models for future action. The ones on this slide are drawn from the pandemic, but I have a few I'll share with you in a moment that are current. So one great example is Sign Health's BSL Health Access Programme, which was available during the COVID-19 pandemic to provide free access to BSL interpretation via video call 24 hours a day. And also, as I'm sure many of you are familiar with, vaccination centres, which were set up during the pandemic specifically for people with learning disabilities and autism to provide an environment with fewer distractions and more time for each patient. We also found examples of primary care leaders working in co-production to create accessible communications resources. And an example we've put there is the General Dental Council, who co-produced a poster and leaflet outlining best practice in complaint handling. We encourage primary care providers to tap into other existing resources and capabilities in the VCSE sector to support people with additional needs to access primary care. And just three more examples for you. We have Seeability, which offers resources to optometry services for people with learning disabilities. Easy Health, which offers free downloadable, easy read format resources on a wide range of health conditions. And Groundswell's My Right to Healthcare cards, which help people experiencing homelessness or living nomadically assert their right to access healthcare without formal identification or a fixed address. We saw those cards earlier today. Can I have the next slide, please? So we know all of this work needs leadership and support, needs moral, practical and financial support from different levels of the health system. And based on the insights gathered, we propose that NHS England should develop a programme of work to support integrated care systems to work with their local primary care providers and people with lived experience of communication to co-design, co-produce and implement actions to support inclusive communication. And some of the proposed policy improvements are on this slide. There's much more in our report. So some of the priorities for action that I've included here are that NHS England should improve training for primary care staff, co-produce standard procedures across health and care for common communication support requests, and share lessons from the recent review of the Accessible Information Standard with primary care teams across England. I mentioned this a few slides ago, but integrated care systems should appoint a named champion at place level to lead on inclusive communications. I think that would be a really important bolster to taking steps towards improvement in this space. And the Care Quality Commission has a role to play here too. They should review and strengthen their approach to regulating primary care services, giving greater prominence to understanding whether services have effective processes in place to meet the communication needs of diverse groups of people. If we can have the next slide, please. Okay, so this is actually the final slide. And just again, to sort of emphasize the opportunities here that we have for positive policy change. My colleagues have already mentioned today NHS England's recent primary care recovery plan. I think that provides opportunities to strengthen knowledge and action in meeting diverse communication needs. And we suggest to enhance the plan for the benefit of those people, we could do the following. We could use national and local support to implement modern general practice access through better digital telephony, simpler online requests, improvement support and investment in care navigation by giving a specific focus on better meeting diverse communication needs. Similarly, NHS England's proposed work to improve the primary secondary care interface should consider how services can more effectively ensure people's diverse communication needs are communicated and met at the point of referral. And finally, the development of national and ICS-led communications and materials to support practices to better meet the diverse communication needs of the people they serve. So those are a few ways in which we could use current policy initiatives to try to drive forward positive change around meeting diverse communication needs. In closing, I just want to emphasize that what I've presented today is an overview of a much richer piece of work. And if you'd like to find out more about the context, the relevant legislation and guidance, who is affected and specific challenges, then please do read our full report. And please also share the learning with your colleagues and your networks. The more that we all raise our voices and call for these changes together, the greater the chances of our nurturing services that will really provide high quality care for people with diverse communication needs. Thank you all for listening.
Thank you, Rebecca, for that excellent presentation on the work and the call to arms at the end there. I think this is something that all of us have a role to play in raising the profile of why this matters so much. And talking about sort of our collective effort on this, we now move on to our panel to come in with their contributions and reflections. And first up, we have Abigail Gorman, who is the Policy and Public Affairs Manager at Sign Health. And Rebecca talked about a few of the things that Sign Health have done on this, but absolutely huge effort from Sign Health during the pandemic to promote the importance and provide service and support for translation and interpreting for the deaf community using services and raising the profile of the importance of this. So Abigail, huge respect for everything you do at Sign Health. Over to you for your presentation.
I'm just waiting for the slide deck. Okay, brilliant. Okay, hi, yes, I'm Abigail. I'm the Policies and Public Affairs Manager. I wanted to talk to you today about how primary care communications would look differently if they were designed with choice, personalisation and equity embedded. If we can go on to the next slide. Okay, so as we mentioned before, we were talking about the accessible information standards you're all aware of. It means that when a person goes to the doctor or any healthcare provider, it makes sure that they are asked for information on their communication needs, that is recorded to make sure that it's there and everybody agrees. It's flagged so that whenever anyone opens that record or that file, the requirements will be there and hopefully met. And then when they go to any hospital, that information is shared so that it's able to be met at wherever they are. hospitals and so on. In 2016, we decided that it needed a review to make sure that it had been working. Sorry, it was set up in 2016. So some years later, we needed to make sure that it was working. So we set up a review so that we could survey patients and healthcare professionals. We got over 1,000 replies in total. Some of the outcomes were actually quite shocking. Next slide, please. So we found that 67% of deaf people said that it was impossible to contact their GP because there was no accessible way to do so. It was based on phone lines. 81% of people said they'd arrived to appointments and there was no way to communicate through those appointments. And 59% of healthcare professionals said that their complaints procedures were not accessible, which meant that 41% said that they were accessible. But what I'm wondering is who said that they were accessible. I'm wondering if those healthcare professionals asked their patients and checked the procedures with them, or if, in theory, that number could possibly be quite a bit more, that actually the complaint procedure is not accessible for more people. What we found is that there was a wide experience of people that felt that there was no access, that they did not seek medical attention because when they were there, they weren't sure if they'd be able to communicate. They weren't sure if they'd be treated. And it meant that people just didn't go to the GP or any healthcare because they felt that they wasn't sure, they wasn't confident they would receive the service. We spoke to people who had not gone to the GP since 2015 because they said, well, what's the point? I know if I go there, I'm not going to understand or be able to communicate. So it meant that there were many people that were ill and becoming worse that could be avoided if there was just access in place for them to get the treatment and seek the help they needed. Next slide, please. Sorry, I tried to do a fancy transition there, which made it a lot slower. Okay, so in 2020, obviously we had the COVID pandemic, and that shook our systems, and everything kind of transferred to phone or in person, but with a lot of PPE, which made it quite difficult for deaf people. Deaf people were put in a really terrible position because of the barriers. There was no access to information on the news. There was no access to the briefings. There was no access to GPs. Healthcare was very difficult, so we decided that we needed to set up access to health. So we had a 24-hour BSL health access for any health provision, from the GP to the dentist to the hospital, ambulance, hospices even, a variety of different services. We had over 25,000 calls during that time. 61% of those calls were to GPs. On some of the busiest days, we would have over 400 calls, and 70% of those calls were deaf patients calling the healthcare provider on the phone. We also covered hospices and palliative care, so people had the opportunity to say goodbye to their loved ones. BSL healthcare access allowed doctors to set up those conversations so people in palliative care could talk to their families. We funded £800,000 of our money because we believed it was the right thing to do. We wanted to make sure that deaf people had access at those times. We did that in conversation with the NHS, who we asked for funding. NHS agreed they would fund it, but only for 4 months. They decided that it was too much money and that after those 4 months it would have to close. So people were calling BSL Health Access. They were so excited to have that service. Even myself as a deaf person, I was so excited. I was excited to call my GP. Why am I excited to call my GP? That's a basic human right. But it was finally accessible for all. Next slide, please. So we said at that point, okay, if you close this service, then we do need a review on access for deaf people. So we decided to set up the rapid review, which was in 2020. The results were actually, the outcome was actually released in August of 2021, and it reviewed deaf patients, deaf organisations, and they decided that for best practice, to make sure that deaf people had equitable access to healthcare provision, Altogether, there would need to be 17 recommendations for the ICS, the Integrated Care System, to be implemented. Those 17 recommendations were beautiful. They were completely agreed. It would give deaf people full access. From that point to now, they have never been implemented. So going back to the original question, how would primary care communications look different if they were designed with choice, personalisation and equity at the heart? Well, we can get rid of that because it isn't. It isn't. We've already told you what we need. We've said what we needed. We've already told the services what needs to be done, but it still isn't. We need those recommendations to be implemented, which brings me to my next slide. The main thing is co-production. That's so important, so that we can have access as a community. We have the knowledge, we have the skill, we have the people with the lived experience. They know what they need, they know how to get it. We need to respect and value their knowledge and their lived experiences. That's valuable, and if we work together, we can actually achieve equity, and it's beneficial for all. Access to health means reliance on the NHS. The problem is, at this point, power. We have everything else, we don't have the power. The power is kept by you, and if you work with us to improve the life of deaf people and share that power, that'll make a massive difference. And if we're not doing that now, when are we going to do that? Deaf people are suffering, and they shouldn't be. Thank you.
Thank you, Abigail, for that presentation that at points made me very angry. The brilliant resource introduced during the pandemic, only funded for 4 months, and just the responses to your survey about the experiences and the actual barriers to care this creates, it makes me very, very angry. But thank you for all the work that you do. Mindful of time, we'll move on to the next speakers. Licia Fear, who's Head of Communications and Engagement for Healthcare Inequalities Improvement at NHS England, is next. Licia, if I can remind you, you've got about 5 minutes, so try and stick to time, and then we'll get to the Q&A after we've been to all the speakers. So Licia, nice to see you, by the way.
Hi Jacob, and hi everyone, thanks for having me. So yeah, a bit of a kind of mouthful for the team I work in, Healthcare Inequalities Improvement Programme at NHS England, but essentially we are the bit of NHS England which is trying to reduce healthcare inequalities across the NHS. So me as a communications and engagement professional, I think anyone that's ever met me or heard me speak before knows how passionate I am about the role of communications and engagement in reducing health inequalities. So this includes not just primary care communications, but all communications that we put out, not just to patients, but the public as well. And the reason why comms and engagement people are so crucial is because we should be providing the expertise on our audiences. We have a national approach to reducing healthcare inequalities called Core 20+5, where we identify certain populations that are most at risk of healthcare inequalities, and 5 key clinical areas as well, which people should be addressing. So that is what ICSs should be acting on in terms of reducing healthcare inequalities. So the kinds of audiences, I'm sure you know, that are at risk of healthcare inequalities, ethnic minorities, socially deprived communities, those with a disability, serious mental illness. We talk about geography as well. So if you're rural or urban or coastal, you can suffer from health inequalities. And I'm sure you've also seen this equality versus equity illustration in one form or another. And I like to bring that up because it does mean that we do have to put more work in to reach the audiences that are at risk of healthcare inequalities as comms and engagement people. I don't like to use the phrase hard to reach. It's our services that are very much hard to reach, as we've heard from people already on the panel today. And it's for us as comms people and policy people to make those changes. Next slide, please. So I speak to comms and engagement people all the time about how we can make our comms more inclusive. I was actually at the Healthcare Communications Association conference yesterday, where I was telling people, I hope you'll be happy to hear how important it is to work with VCSE organisations and make comms as inclusive as possible. And this is the one thing that I like people to go away with. So if you only take one thing away from any of my presentations, it's think about who are you not talking to. So if you are developing any communication strategies or plans, think about the different groups, you know, put yourself in the shoes of the different groups that are at risk of healthcare inequalities, and think about, actually, are these people going to be able to access this information, understand this information, hear this information? And if you can think in that mindset, that will hopefully encourage comms and engagement people to think differently about how they present their communications. Next slide, please. And there's lots of ways that comms and engagement people can do that. I like to put these up just so people have some practical tools to take away. But knowing your audience and knowing what their challenges are is really important. I really welcome the report that's come out from National Voices. I had a good read through it yesterday, your inclusive and accessible comms report. There's some brilliant stuff in there. I agree with all of the descriptions of what makes good comms and the enablers. And I think it starts with understanding your audience. So there are lots of different ways that you can do that. We know that poor communications widens the health inequalities gap. But on the flip side of that, we know that great communications can help to narrow the gap. So make sure you know about your communities and what information that, what communications preferences they have, and kind of you can get that from internally. There's lots of public information on the censuses. There's community groups. I'm really passionate about the power of co-production and involving people in developing communications. And there's also insight as well. So insight, we can do big insight projects to find out about certain communities. It's not always the cheapest thing to do, which is why we try and do a lot of insight gathering at a national level, so that we can feed that through across our programmes down to ICSs, and also sharing with our VCSE and stakeholder partners as well. And we've tried to do that for, oh, sorry, I just heard some background noise then. We've tried to do that for a couple of audiences. So next slide, please. Oh, I thought this was a slide before, but this is another little tool that you can have to audit your communications. So as I was saying, step into that role of the different groups at risk of healthcare inequalities, but also think about your tactics as well. So language, are you using, you know, what language are you using? Could it be illustrated instead? Could it, I'm very torn with translations. A lot of people say, oh, I've translated an English language in 20 languages and that's my job done. For ethnic minority communities, doesn't work that way, unfortunately. How are those leaflets in different languages actually going to reach people? Have you got a telephone number on that leaflet that when someone who reads it in Urdu calls that number and actually someone answers in English, that's not very helpful. So think about language, English proficiency, think about faith, which can deal with timings. You know, it's Eid at the moment. Is this a good time to be putting out, you know, messages? Some messages might be better than others to put out at certain times. Think about diet and the different, especially if we were talking about public health and food, you know, what food should you be kind of illustrating in messages? Clothing as well, of people that are included in your communications, awareness of health topic and health literacy. Next slide, please.
Just a time check. Yeah.
Yeah, this is my last one. So this is these are just a couple of tools that I will put the links to in the chat of some insight work that we've already done to help people. So the first one does have type 2 diabetes on, but ignore that because there's loads of useful information there for communicating with Black and South Asian communities about a variety that can be applied to a variety of health messaging. Our most recent one, which people have said that they need a lot of help with, is how do we better engage with socioeconomically deprived communities. So there's loads of information in there, loads of practical tips and advice. Both of these have been developed with people from the relevant communities as well and available online.
Thank you, Licia. Maybe you want to share the links to those in the chat when we get to appropriate moments, but thank you. And again, really pleased to see the strong calls for the importance of co-production with communities and the people affected to get the communication right. It really goes to the heart of understanding your audience. So our next panelist is Gary Borley from who's the Membership and Engagement Lead at Learning Disability England. So Gary, over to you.
Thank you. Can you hear me?
We can.
Yeah, oh, good. Can I have the slide on, please? I'm going to talk to you about how can primary care communications be more inclusive and accessible for people with learning disabilities. I have to tell you, I'm Gary Borley, and I've been a self-advocate for 37 years, and I'm also the founder of Learning Disability England, and I'm the Membership Engagement Lead. Next slide, please. What does good look like? It needs to be person-centered, so the person is in the middle is the person that needs to be the person's needs, and people need to be being treated with dignity and respect, and they need to be also properly supporting patients who are unable to communicate verbally. A lot of people with learning disabilities I know of use Makaton instead of BSL, and they also probably use communication aids as well as that. So those sort of things are very important and should be provided. They should not be to pay for communication aids. That should be freely available from the NHS. Accessible communication offered across the board. That's what I'm trying to say. Supporting people to have a greater understanding of what is being conveyed to them. My neurologist took them 45 minutes to explaining everything over and over again, because I can't remember lots of things, and there's a lot of medical jargon, and I need it to all be explained to me. And recognizing all humans use many ways of understanding and expressing themselves. So some people may need like hospital passports, if that's going to be a way for them to know their medical history in that, and if they can't verbally speak for themselves. Also, inclusive communications that benefit everyone. Easy read information is very important for people with learning disabilities, and pictures and photo symbols are very important. Photo symbols, pictures should be on the left-hand side, and the wording in Arial on font size 14 on the other side, and that should be like black on white paper. Next slide, please. Using everyday language and avoiding jargon. As I said, there's a lot of medical jargon out there, and some of us need to be explained what medications we're taking, and also there's a lot of people with learning disabilities also their English may not be their first language. It could be second or third language as well. Sorry, is that speaking directly also to patients regardless of degree of learning disability. So I have a mild learning disability. That should be, accepted, as well as people with a more profound learning disability. Identifying how someone communicates they are in distress or in pain. Some people may not understand if they're in distress or in pain, you see. So it's a lot of these things, and a lot of people with learning disabilities don't reach after their age of 30. That's what happens to people with learning disabilities. Healthcare professionals need to understand the likely cause of challenging behaviour. The word challenging behaviour, I think that's something that the doctors and medical professions use. And if people are crying out for pain because of pain and distress, they think that's a challenging behaviour. Also, de-escalation over restrictive interventions also, that needs to be sorted. Making reasonable adjustments. This could mean finding a quiet space to speak to the person, or allowing a visit before an appointment to allow a person to familiarize, because there's big, strange hospitals, they can be scary places for some people with learning disabilities, and to see other people, and that could be a scary thing for people. Next slide, please. Using gestures and facial expressions and checking understanding. Some people don't use, as I said, don't use words, and so they may use other ways, like, as I said, they might use Makaton and sign language. Supporting non-verbal patients, physical touch might reassure, kneeling for those in a wheelchair. Giving people time and speaking slowly, it helps people like myself and other people with learning disabilities. Using visual guides or cues to aid communication. Exploring atypical methods, example, different sites for access, alternative locations for health checks. It's also important that we're not talking about GPs, what we're talking about dentists, hospital doctors, like neurologists, and our pharmacy. They all need to work together, and they need to all be funded to give us a better service for all people with learning disabilities. It's like my medication at the moment. A lot of the chemists have stopped putting pills into dosette boxes, and are supposed to be transferred from one epilepsy medication to another, and I'm unable to do that because I get confused. Next slide, please. That's it. I think I said it all. I hope I haven't gone over too long.
Gary, that was perfect. Thank you so much for your reflections. And I think actually just the point you raised about how scary it can be for people with communication challenges. This is not just about understanding or accessing care. It can, that can be a really intimidating environment, and without the right support, people can be left very, very scared and upset and distressed. So really important presentation. Thank you. We'll move on to our last speaker, Mihai Beaker from who's the campaign and policy coordinator for Roma Support Group. So Mihai.
Yeah, thanks very much, Ken. Hi, got the slides on. Yeah, as you mentioned, I work at Roma Support Group, it's a charity based in London supporting Roma migrants who live in London and in the UK. More information about us is available on the website mentioned on the slide here. Can we have the next slide, please? I'd like to take you a little bit through why we're discussing about Roma in this context, just to familiarize everyone here about us. We're a community originally from northern India, where we started migrating about 1,000 years ago. We are split today in different groups and tribes of Roma. There are about 12 million of us living all across the world today. So we speak different dialects of Romanes language, which are passed orally and have always been passed orally throughout the history. We also speak the language of the country we settled in at different times of the history. And if we move on to the next slide, please. In Europe, we've started to settle about 600-700 years ago. Again, throughout the latest sort of centuries, there is presence of Roma in Eastern, Central European, as well as Eastern, Western European countries. About 6 million of us in EU, and we've seen in the UK, as of the last census, at least 100,000 Roma living here. Now, it's also important to mention that there are high levels of negative views against those from the Roma communities, and they have been high throughout the latest centuries, meaning that Roma have a hard time at getting access to education, and therefore many of us have limited literacy, many of us have limited education in general, and we struggle in terms of communicating, especially in the health settings, because of the low literacy levels, because of the low education levels, and because of the negative engagement, previous engagement in countries of origin with the health services. And if we move on to the next slide, I'll go into some specific about the Roma who live in the UK. When we look at the kind of use of health services in general and issues that people are reporting to us, Roma are saying to us that most of their health concerns are in relation to diabetes or cancer. They tell us that they usually work in poor work conditions. Also, smoking is at high levels, and this is influencing most of the health concerns that Roma people have. They mostly use A&E services and GP practices as well. And the main barriers mentioned in general by Roma are in relation to language, long waiting times, digital exclusion, again related to that level of education, lack of trust in health specialists, and past discrimination experience. And moving on to the next slide, specifically in terms of communication, the challenges that we have specifically to UK, but can be applied in other parts of the world as well. We've tried to split them in a few categories. And in terms of cultural changes, we see that what impacts a lot on communication is where we have opposite gender interpreters especially if they are from the Roma communities themselves, and also speaking about more sensitive health issues over the video or mobile phone. So for example, if we have a woman who has a specific woman health related issue and we have a male interpreter, even if it's from the Roma community, she might not disclose that issue in front of that male person because of the cultural background and so on, which leads to wrong diagnosis or partly diagnosing the issue and not getting access to the right support. Also, we've seen increase of use of video appointments over the phone appointments, and we've seen that again, when there are sensitive health issues, people when they realize that their appointment is over the phone, they've reported a completely different health issue to the one that they actually initially wanted to speak about, because they just felt ashamed to speak about that particular issue over the phone. In terms of skills, we are seeing in the Roma community high levels of illiteracy and functional illiteracy, meaning that people are not able to read text, written letters, or are not able to understand the content of letters, leaflets, or what they read on websites, for example. There is a lot of difficulties with form filling, and it's a huge barrier. Digital exclusion is another important barrier to mention. We are seeing that Roma do have access to a smartphone in general, but they are not using that to access internet websites. They're using that mostly to communicate with family, relatives on social media, and to make phone calls and so on. This means that accessing websites, using apps and so on is very limited. It does help, for example, use of Google Translate. We've seen that a mean that Roma people are using to try to communicate with health specialists. So they will go to a hospital, a GP, and then they will use that to be able to communicate. And language, low levels of literacy. Yeah, I'll move this.
Yeah, thank you.
Language is another one. We're seeing low levels of English as well. Our own language, Romanes, is limited in vocabulary. So when we have an interpreter, it's very important that the health specialists try to explain what they are speaking, so that the interpreter explains that as well. And in terms of the system barriers, again, it was mentioned before, difficulties booking appointments, non-Roma interpreters. We've seen that in many cases carry their own negative views on Roma, and this is impacting the interpreting process. This is an important one to bear in mind as well. Another issues often reported by people is attitudes that GP receptionists have. And they can be in relation to people not speaking English. They can be in relation to, sometimes to people being from the Roma communities and so on. And these attitudes are reported quite often as a barrier. And moving on to the final slide, in terms of enablers and what it helps, we've seen it helps to have interpreters from the same gender and also similar age. We've seen that a gap, age of 10 years, up to 10 years is generally accepted. We've seen communication through images, pictograms helps, but they should avoid things like naked body shapes or genitals. Also, audio messages are helpful, especially if they are in the relevant language. Offering face-to-face appointment also always helps. In terms of skills, training and employing staff to understand the cultural background of the community, experience that Roma have in relation to communication allowing extra times during the appointment so people can have a full kind of communication there. And in terms of the system, always try to provide alternative communication methods so people have access to either video appointments or written as well, because it does work for some. Asking language providers to source Roma interpreters, it's always helpful, or try to work with bilingual community advocates, which can help with interpreting, but also with explaining context. And finally, try to record issues created through the interpreting services, such as recording patient satisfaction against interpreting services. We've seen often people having issues because they turn up to appointment, the interpreter was not there, or the wrong interpreter was there, which led to wrong notes being recorded into the system, and people had complications after that. So that will summarize my speech. Thanks very much.
Thank you, Mihai. That was excellent. And that last point, particularly about the capturing the feedback about the quality of interpreters, is so critical across the board. We've got time for just a couple of questions, so I'm going to go straight to Pavi if we can. Pavi, perhaps if you could give us your 2 best killer questions from the audience, please, and we'll run through those.
Yes, of course. First question: how do we move this beyond a conversation about communications and more about a fundamental barrier to access?
That's a good question. I'm going to go to, I think I might pick on Licia for this one first. Like, often we just talk about this is not just comms, it is an actual barrier to access, but as a comms professional, how do you get your other colleagues to recognise it's not just about the comms?
Yeah, that's a brilliant question, and if I could do that today, that would be very helpful, wouldn't it? So I speak to a lot of comms and engagement people, but then I also speak to a lot of policy people as well, in trying to make them understand what the barriers are. And I think the conversation around access, experience and outcomes, which is what we focus on around reducing health inequalities and communications, they're the 3 main things. So access, what are people's access, can they access it, what is their experience, and what are their outcomes, and really talking to, we as a team are talking to anyone and everyone that will listen about those 3 things. But more suggestions welcome, as always.
Thank you. Fellow speakers, Abigail, Gary, Mihai, any thoughts on how we move this from just being conversation about communications and get people to really understand that this is about blocking people from the care that they need?
Well, I think that element of training or further discussions is very much needed at local level. I think having those GP receptionists, for example, more active, more proactive, trained properly, giving more time to people to hear, to speak with them, and so on, could make a huge difference. So those conversations at local levels are very much needed for things to move forward. So,
thank you, Gary.
We need more, in the words of action, than words. There's a lot of words and promises that will want to change things for the better, but I think we need more in the way of action, and because we always get downhearted when we get to people with learning disabilities to talk about any issues surrounding them. And what we do really need is action. That's what we need. No more words.
So more action, fewer words, more local, what we need. And Abigail, I'll come to you for the final word.
Yes. Oh, sorry, 1 second. Yeah, I totally agree with Gary. I really do. There's so much work. Like I mentioned before in my presentation, we've already listed the recommendations. We've already done the work. Sign Health has the expertise. We've created these these recommendations of what we need. We do need training, yes, definitely, because the NHS have a high turnover of staff. So that means that, you know, the training is missing. So we really need to go back to when we're studying, as nurses, we're studying as nurses, and embed access into that training right there. So it's always in the consciousness of professionals, because it creates a false economy at the moment. We're paying for this training and for this access, but the access is becoming worse. So what we're spending now is to try to make sure that we're preventing it getting even worse later. So really, if we go back to action, I know it will cost more down the line without it. So if we look at co-production with the people who've got lived experiences at the panel, and having those conversations with all the GPs, the doctors, they should be having that conversation over access. So we need to look at how we can make these changes now to make it better, working with people with lived experiences, so we have more knowledge of what they actually need. It really does go back to co-production with the people.
Thank you, Abigail. That is it for time. So I've heard a call for co-production. I've heard more local, more action, more resource going into this. And for me, being a bit angry about this, actually, the state of affairs is not good enough. We've got the answers, we've done the research, we've asked the questions. Now we need to see some action. So thank you to all of the panelists for taking part in this session. There is a link to the report in the chat box, so please do go and access that and share it with colleagues. Get out there and let's make some noise about the lack of accessible communications at the moment. I also need to say a big thank you to our sponsors for this event. So this session was sponsored by the Department of Health and Social Care, NHS England, and the UK Health Security Agency, who provided a grant fund to the VCSE Health and Wellbeing Alliance, and it's through that this project has been funded. I also need to say thank you to the primary care transformation team in NHS England for all of their insights and advice they've provided into this independent piece of work. So thank you very much. We wouldn't be able to do this work without the work of our sponsors as well. And thank you to the Health and Wellbeing Alliance partners and the lived experience participants who all took part in the research and contributed. And a particular thanks to Aliyah Benjamin, who's our project insight manager at National Voices, and she's played a particularly important role in this project. So thank you to everyone for taking part, and thank you for contributing to this session.